Yeah, I saw Kanishka not there, no?
Yes, sir. Yes, sir. I'm there, sir.
Aarti, one shot. Okay. Start. So we are at the last topic of CNS. One more is there. What?
More is there, sir.
Huh?
One more is there, sir, vascular lesions.
Okay. The presenter herself didn't know. Oh, 11. Yeah, she didn't know. Yeah, should have told. Okay. Vitamins. What is vitamins? Thursday night party. அவனுள்ள போட்டாதான் vitamins CNS what Viveka and Saranya should be able to do vitamins. Tell. Be sportive and tell. Micromolecules which help. Okay. What about others? CNS is going on, and in that, if I say vitamins, stands for vascular, infective, trauma, autoimmune, metabolic, immunologic, neoplastic, structural. It's a mnemonic for etiological assessment of any central nervous system symptom, sign, disease, okay, of which not everything applies to us, but some of them will apply. Okay. So remember that when you said vascular instead of hemorrhage, then it came to my mind. Okay, proceed.
Good morning, everyone. So we'll discuss today about a few CNS infections and their manifestations in the fetus. So when do we get a trigger for evaluation of a congenital infection? There can be 4 scenarios with a patient presenting to us. It can either be a symptomatic mother or tested for a infection and a positive serology has turned up on investigations. An abnormal ultrasound sign when you pick up on a routine ultrasound or you seek for it on an ultrasound examination, or a previously affected baby and they have come for a subsequent pregnancy for evaluation. So all this needs a targeted ultrasound examination to detect if there are any signs of infection and the sequelae. So we have the TORCH infection, which stands for toxoplasma. The others include the parvovirus, varicella, Zika, and syphilis, cytomegalo, herpes virus, and all these have some diagnostic signs on ultrasound, but not all stand for always. So whenever we evaluate a patient, the history taking is important because our line of thoughts go into or try to narrow down on a single symptom, though we may have multiple ultrasound signs. So whether there was a presence of a vesicular rash or a non-vesicular rash, or a facial rash, or history of any exposure to toxoplasma infection or any travel history, which may particularly indicate a Zika virus transmission. Then we look for an ultrasound examination where we can have a presence of ultrasound signs.
Now, if you're dealing with international patients, okay,
Yes.
then it becomes particularly important to know what is prevalent in their place. For example, here we deal with a lot of French patients. They come now, if they get pregnant, then they tend to show up here, or they may be visiting Oroville, they want. So then CMV is a particularly important condition in that country, CMV. Okay. So you need, in those cases, you need to definitely ask whether you have done a serology or not. Okay. Proceed.
There are no diagnostic signs as such, and all the signs need not be present in a single fetus. So signs suggestive of infection should further trigger testing for these infections. So some of the ultrasound signs which are suggestive of a fetal congenital infection, they can be cranial or extracranial abnormalities, and some including the fetal environment. So the cranial abnormalities can include ventriculomegaly, calcifications, cerebellar abnormalities, and malformations of cortical development. And extracranial abnormalities like small for gestational age, hyperechogenic bowel, hepatosplenomegaly, liver calcifications, ascites, pericardial effusion, or an high drops of fetal anemia. And the environment, including the changes in amniotic fluid and the changes in the placenta. So we'll see some of these now. So the ventriculomegaly, so this can vary from a mild ventriculomegaly or a borderline ventriculomegaly to a severe dilatation of the ventricle. So here in this axial section, we can see there is dilatation of the ventricle with calcification along the ventricular wall and also echogenicity seen along the ventricular walls. Here we can see there is dilatation of the third ventricle. In this coronal view, we can see that the ventricular walls are, there are periventricular calcifications and the ventricular walls are irregular, and there can be some contents seen, debris seen in the ventricle. Here in this sagittal section also, we can see the periventricular calcifications and the irregularity of the ventricular walls. There is one more sign which can be seen, the periventricular halo, which is seen as an echogenicity around the ventricles. And this could be indicative or positive towards a CMV infection. Here also we can see the echogenicity around the ventricular wall. Can also have calcification. So in this axial view, we can see that there is ventriculomegaly with calcification along the medial border of the ventricular wall. And here we can see multiple calcifications, parenchymal calcifications and calcification in the caudothalamic group and periventricular calcifications. So all these can be indicative of an fetal CNS infection. So this coronal view shows the dilatation of the ventricle with intraventricular synechiae formation.
So representing an inflammatory process going on.
There could also be cerebellar abnormalities like hypoplasia unilateral or as such cerebellar hypoplasia, Vermian hypoplasia, cerebellar hemorrhage, and calcifications and cysts in the posterior fossa. There could also be malformations of cortical development Here we can see in this section, there is a part of the corpus callosum, which is dysgenetic or malformed, a portion of it not seen. And in this coronal view, we can see that there is a smooth brain. There is loss of sulci parenchymal pattern, and there is increased space, calvarial space, which we can see, and also calcifications we can see along the ventricular wall and multiple calcifications here in the cortical matter also, indicative of a lissencephaly. Same patient, we can note the calcifications in the cortical matter and a discrete calcification seen also along the ventricular wall. There could also be extracranial abnormalities. So whenever we evaluate not only the CNS, we should also look for the extracranial manifestations, or an extracranial manifestation can lead to an for us to further evaluate the CNS part. So it could be just an hyperechogenic bowel. So all these can be either be isolated abnormalities also. So here we can see the hyperechogenicity in the bowel area. So in this clip, we can see there is fluid collection, which can be seen, and there is hyperechogenicity with some echogenic material filling the bowel loop, and we can see the peristaltic movement also. So that could be hepatosplenomegaly. This coronal section shows the enlargement of the liver, and this section shows there is enlargement of the spleen. There could also be liver calcification. So we can have a discrete, a single calcification as seen in this image, a single large calcification. Or we can have multiple calcifications where we can see in the liver surface area as well as in the parenchyma, predominantly over the liver surface. So all these could indicate a infective etiology, or could be other vascular causes or other genetic etiologies also. So there's nothing like diagnostic. There can be an overlap and we need to further investigate. So similarly, we can see a echogenic bowel with insipated echogenic material in the bowel. And here we can see a isolated dilated bowel loop with calcification along the bowel wall or in, near the bowel wall. So we can have also a thin rim of ascites of fluid collection in the abdomen. Or that can be more prominent than as we see here. There can also be some fluid collection. Also fluid collection in other spaces like the pericardial space as well as the pleural space. So it can all be mild to severe. So let's see a case scenario. So we had a patient who presented to us for a second opinion for suspected corpus callosal agenesis and prominent subarachnoid space. So she was a second gravida with previous live child born out of cesarean section, and this was the second pregnancy. So on CNS examination, we found that there was the measurement of the corpus callosum was on the lower side. It was CC hypoplasia. And also here we can see the cerebellum, but we don't, the measurement was lower for the period of gestation, and it was cerebellar hypoplasia.
Got the fourth ventricle.
Narrows. It is horizontally rectangle. It has to be vertical rectangle.
So it's a misshapen fourth ventricle, meaning that the vermis is not formed well.
Also in the axial section, we can see the intraventricular synechiae formed inside the ventricles, and also we can see a prominent third ventricle.
Okay. In the here also you can see, what is this? Yeah. Increased echogenicity in the periventricular regions. Okay.
Okay,
So that can be very subtle. You should be looking for it.
okay, sir. And further evaluation, we saw that there was calcification seen in the parenchymal region, and
It's a shrunken cerebrum. Can you see?
yes,
It's
sir.
just shrunken. There's a lot of space outside, and you can see that there is an increased corticocalvarial space, and there is prominent ventricles. Okay, so ex vacuo dilatation of the ventricles.
Here we can see the increased echogenicity of the ventricular walls and periventricular calcifications along the ventricles. So we had the finding of multiple intracerebral cerebral calcifications with intraventricular synechiae, periventricular echogenicity, loss of cortical volume, corpus callosal hypoplasia, cerebellar hypoplasia, and also we had additional extracranial findings of an adrenal calcification and a hepatomegaly. So we have counseled the couple along the following lines. So the constellation of findings overall indicates a poor prognosis, and the findings are likely secondary to transplacental infection or a single gene disorder. And we had advised amniocentesis for torch PCR and DNA storage. And the couple underwent an amniocentesis, and the pregnancy was terminated. So the torch panel report showed a positive result for cytomegalovirus PCR. So after the termination, when the couple had reverted back to us, we had counseled them that the findings are secondary to transplacental infection, which was confirmed with torch PCR performed on the amniocentesis sample, and CMV infection for the current subtype provides immune status for the mother, but the chances of subsequent reinfection by other subtypes or infection by other subtypes very rare, but cannot be completely ruled out. And we had given her the pre-pregnancy counseling. So the cytomegalovirus is a human herpes virus, and it's the most common viral cause of congenital infection, amounting to 0.2 to 2.2% of all live births. And it's a leading non-genetic cause of sensory neural hearing loss and a major cause of neurological disability. So most of the maternal infections are asymptomatic, and even if they are symptomatic, it will usually include like a flu-like illness with fever, malaise, myalgia, cervical lymphadenopathy, and less commonly hepatitis and pneumonia, and it can mimic some other infections with similar symptoms also. And it can also remain dormant at particular sites and can be reactivated at any time, including during pregnancy. The neonatal infection among 10 to 15% are symptomatic at birth, and 25% of the infected children have long-term impairments. So we can categorize the maternal infection as primary infection and non-primary infection. So the non-primary infection is due to reactivation of prior infection or reinfection with a different strain of the virus. So in a primary infection, when the mother is affected for the first time, the transplacental transmission is more likely than in a non-primary infection where there already some amount of immunity and the transmission is less likely. So the risk is in the order of 1 to 2%, whereas in a primary infection, it almost as high as 30 to 40%. So there is some studies have shown that there is some risk of transmission even in the preconception period. And the risk of infection increases as the gestation advances. Usually in these torch infection in the early pregnancy, the risk of infection will be less because it's said to be due to a smaller placenta. And but the severity of infection, if early onset, is higher. So as we can see here, the risk of infection increases from almost 0 to 10% in the preconceptional period to almost 47 to 78% at the third trimester. But the severity of infection gradually decreases. It's more severe in the preconception or the periconceptional period and first trimester as compared to the third trimester.
It's not true universally about the severity.
Okay, sir.
For example, chicken pox can be severe in the perinatal period also. No?
Yes.
So the thing we have to understand is early in pregnancy when the mother is infected, the chance is less, but it's going to be very severe. Okay. Yeah.
So the risk of congenital infection, as I said, it's around 30% in the first trimester to almost 47% in the third trimester, and severe is higher when it's in the first trimester compared to the third trimester. So the maternal serological testing for CMV. So when do we act on it? So when the mother has an influenza-like symptoms or symptoms of glandular fever, as we already said, lymphadenopathy or mild flu-like illness, with negative test results for EBV virus because the symptoms of the EBV virus are similar, or symptoms of hepatitis which can rarely occur with CMV infection also with negative test result for hepatitis A, B, and C, or we have an ultrasound findings of a cranial or an extracranial abnormality. So let's see the immune response pattern after an infection.
Click on click on this. Now you do. So
whenever there is an infection, we usually have the IgM, which starts increasing approximately after a week after the infection, and it goes up, peaks at around 1 to 2 weeks, and then gradually falls down to around 3 months, and then it almost becomes negligible around 7 to 8 months.
So the yellow band is the threshold of where the lab will call it present, positive. Understood?
Yes, sir. Whereas the IgG starts increasing around 2 to 3 weeks after the infection, gradually increases, peaks around 3 months, and then it plateaus and stays lifelong. There can be a
pattern B response.
Where there's a small subset of patients where there is an increase in the IgM early after an infection, and then it persists for long, and this can always confuse us with whether it's going to be early infection which was like less than 3 months or 4 months, or it was a recent infection or a reinfection. So we need to be wary of this pattern of IgM persistence in CMV infections. And the IgG avidity, it keeps on increasing. So initially it will be a low avidity where there is usually after an infection polyclonal B cell stimulation. And once it gets the B cell becomes more mature and starts producing more specific antibody, the avidity keeps increasing and the IgD avidity, high avidity persists. After 6 months, it becomes a high avidity.
Go back. Slow. One more. Okay, so we need to spend time on this because when we understand this, then your management of the torch report becomes better. Okay, all of you will be bombarded by torch reports, and based on the combination of the IgG and IgM, you have to then take action. It's very important. Okay, so look at this. IgM is increased if it is a recent infection. Okay, and it will die down After the recency is over, after the immediate period is over, it dies down. Okay. This is seen in the vast majority. Then IgG starts, and if you have a situation where the IgM is out, is not reportable, and IgG is positive, so if you're here, you can say that the infection was quite remote, 3 to 4 months before. Okay, it's not recent. So somebody early in pregnancy comes with a report, IgG positive, but IgM negative. Okay, good. So it is a remote infection. It is now called as an immune status. All right, immune status. So in this situation, we can reassure for that virus, you are less likely to get infected during pregnancy. You are immune. For those viruses where you are not immune, you stay away from children, from pets, all those things we can give advice. Able to understand?
Yes, sir.
Sure. But now there will be a fraction of patients who will show a different IgM response. It's called the pattern B response. Okay. In pattern B response, the IgM will initiate all right immediately after the infection, but it tends to persist. It won't disappear. It won't start declining immediately. Okay. The usual time for IgM is just 2 weeks. After that, it will start decreasing. But here it will persist for months. Even up to a year also it can persist. And this phenomenon has been observed in different viruses also. It was very much spoken about with respect to CMV, but it's also there in other viruses. So we can't really be sure whether it is virus specific or patient specific. Now what happens is, forget the blue now, only the yellow and the gray are present. Okay. So if you have a strong Ig, let's say here, IgG is positive, you expect the IgM to be negative, but because the pattern B response, your IgM also will be positive. Okay. So see this portion. Here also IgM is positive, IgG is positive, you are still a recent infection. Okay. If you take here also in pattern B, IgG is positive, IgM is positive, you may still be you will think you are in a recent infection, but actually it's a remote infection now. The IgM should have died down, but it's still persisting. All right. So in such situation, the confusion should be cleared by looking for the avidity. Avidity is the maturation of IgG. The more it matures, the more time it has had to engage with the antigen, the more strongly it will bind with the antigen. So if you see more avidity, that means it's a remote infection. Okay. Each lab will have a slightly different cutoff, but by about 60 to 70% avidity if they report, then you can say that it is a past infection, at least 4 to 6 months, and risk of transplacental transmission is negligent. Understood? So if somebody comes with both IgG and IgM positive in the first half of pregnancy, then you should ask for a IgG avidity. Chumma avidity. So, of course, the lab should know that, but you can't really. If the IgG avidity is reported high, then you can reassure that the risk of transplacental transmission is negligible. Sorry. So this slide, very important. Keep looking at it. All.
So as explained, so when there is an IgM negative and IgG positive, already there is an immune status and there is no need for further testing. When IgM is positive and IgG is negative, then also it means an acute maternal infection. There is no need for avidity testing.
Hold on, go back, go faster. There's a processing time.
Yes.
So you see the report, maternal serology. IgM, you start with IgM, okay? IgM is positive, all right? That means the mother is mounting a immune response to a recent infection, okay? If it's really recent, she wouldn't have time to prepare the IgG, so you shouldn't find it, correct? So IgG should not be there, okay? Next. So that is this. The second line is the acute infection going on. When you know this, then there is no need to go and check the avidity for IgG. It's not going to be there, so avidity also cannot be reported. Got it? So that is now a situation where the mother has recently acquired and she is actually preparing her body for immune status against that virus. Okay. What you can do to confirm that is wait for 2 to 4 weeks and repeat the IgG. Okay. And if it becomes positive from negative, which is called seroconversion, then you are very sure that originally when you saw, she was preparing immunity for a recent infection. Okay, understood. So that's called seroconversion. Seroconversion is also an important strategy to confirm. So for example, somebody comes at very early gestation, okay, IgM positive, but IgG negative. Okay, you may think that it is definitely infection. It may not be. IgM is quite non-specific. You can get cross reaction. Somebody else would have come and your torch IgM will increase, but it will borderline only it will increase. Anamnestic reaction. Okay, so the cross reaction can confuse us. So in that case, say at 6 weeks booking visit only IgM borderline. IgG not there. Don't jump and say, oh no, you are infected, baby is going to be infected. No, it's not like that. You wait for 2 to 4 weeks and repeat the IgG. If it is still negative, that means that IgM was never a true original IgM. That is some cross reaction. So you don't have to worry about it. Okay. Okay. Now go to that is the first. Now that is second. No, leave it. Now go back. So you test IgM, you don't see, but you see a nice strong positive IgG. So you know that the initial phase has died down. A remote infection 3 to 4 months ago, at least. And if you have good IgG, then you know it is not a recent infection. So no further testing for the mother. All right. Yeah. Now, the confusion comes most often when the situation is you are testing IgM is positive, IgG is also positive. So then what to do? Should we count it as a remote infection, recent infection? The situation can happen in both. Okay. In recent infection, at the threshold of IgM, IgG transition, you can get both positive. And in remote infection, many months ago infected, but the IgM is still lingering on. Pattern B, there also you will get both positive. So this situation can be clarified by
Avidity. IgG avidity.
IgG avidity. So you are now asking the question, IgG, how old are you? I am very old, means it will be very mature and the avidity will be very strong. So you can say, okay, this is not a recent infection scenario, just pattern B, IgM is persisting, right? Yeah. So if it is low avidity, then the G is not mature enough to go and grab the antigen. That means very recently infection happen. It's pattern B, but recent infection. Okay, low avidity. Yeah. So remember this table, and by logic, if you know the pattern of response, then you can always reconstruct this in your mind, but have it as a quick table. Yeah.
So in the last scenario, where we have a positive IgM and positive IgG, we need to do a avidity test, same like the third scenario. But when we have an IgG high avidity result, then it means a remote maternal infection more than 3 months. So the low avidity index includes less than 30% result, and high avidity when there is more than 60% indicates a past infection or secondary infection. So the diagnosis of maternal infection based on the appearance of CME specific IgG in a woman who was previously seronegative, or detection of CMV IgM antibody and a low IgG avidity, which was the third scenario. And non-primary maternal infection also cannot be excluded using serological tests. So as we discussed, the pitfalls may be that the IgM may persist for many months after primary CMV infection, as in the IgM pattern B, which we saw. And IgM may be detected even during a secondary infection. And there's reactivity due to other viral infections like EBV virus.
So, correct. That's what I wanted to say.
So always we have to do an CMV specific IgG testing in parallel with an IgM testing, so that we know what is the whether it was an acute or a past infection.
What we do here is we always order IgG, IgM, and IgG avidity. Okay, so when you have all three on the table, the interpretation is less confusing. Okay, so it's very important, because when you make it, the initial impression, patients will think that the moment they see something positive on the report, stress level goes up. So get everything. Another thing I tell my patients is that I will order this test, but only I should interpret. Nobody else should. So get the report and come only to me. You also should not try to see the report. It's very important.
The diagnosis of fetal infection is by CMV DNA on PCR analysis of the amniotic fluid. The timing of amniocentesis is important. So at least 8 weeks should have passed from the estimated time of maternal infection and after 20 weeks of gestational age. This is because some amount of maturation is needed, and for the urine production to be sufficient so that we are able to detect the CMV DNA in the amniotic fluid. And the most significant risk factor for false negative result is when you do within a very short interval, or when you do an amniocentesis less than 18 weeks.
So what happens after an infection? What happens? So the infection happens through the umbilical vein, isn't it? The placenta gets infected, then the umbilical vein carries the virus down the umbilical cord, and the first phase to land is the liver. And then there will be some inflammation, fighting going on in the liver, the reticuloendothelial cells, and then the barrier is breached. Then it becomes systemic. Okay, it can go to the brain. But we were discussing that only, no? It can go to the peritoneum. It can go to the kidneys. Okay, mostly contiguous spread will precede circulatory spread. So you will see peritoneum more often than CNS or kidney. Okay, so once it has spread to the kidney, then it will start getting excreted in the urine. Understood? But you need sufficient strength to be excreted so that you will be able to detect. For all this to happen, the cutoff is 21 weeks. Okay. So the traditional cutoff is 21 weeks to be able to detect in the fetal urinary excretion, which is what you test by amniocentesis. So if you are, very quick to put the needle, you will miss it. Okay. So suppose there is a indication to do an amnio. You think there are some signs, mild hepatic calcification, but you are doing it around 19 weeks. Okay. You might miss. Then on follow-up, the CNS signs would appear, and that will appear like full-blown, even though you would have tested the torch PCR. Got it? So you need to wait for that little bit. And here is where the importance of history taking also comes. When did you become seropositive? When did you have the symptom? When did you travel to some place? So all those things we should know. So that in your mind, whether you have allowed that 6 to 8 weeks after the infection, that will happen. Okay. And this is true for all torch infections. You have to allow sufficient time from the infection for it to manifest. So seropositive, baby looks clean, don't reassure. You need to wait. And before 21 weeks, don't put the needle. Okay. But having said that, that was traditional thought process. Having said that, now there are centers who have reported that between 19 and 21 weeks also, they haven't missed much. Okay, so this is from centers where CMV is rampant and they keep doing amniocentesis. They're okay to do early and second time also, whereas our patients don't want to do that, isn't it? So when they compare 19 weeks and 21 weeks, 19 weeks work just as well in the majority. But we don't want to take that chance. TORCH PCR takes about 5 days. At 21 weeks, you can still give the result by 22 weeks. And if it's an infected baby, they can still go for termination. It's not, rather than doing at 19, patient gets reassured and goes away. Understood?
So in cases where we have only ultrasound signs, but no history-wise, no symptoms, and we'll do simultaneous testing of the baby and the mother.
Okay, so this is a good question. We have, as a policy, moved away from testing the mother because of all that we have seen. There can be confusing thing, and maternal testing does not fully guarantee that you can exclude only based on the mother. And TORCH PCR is very sensitive. In the right lab, it's very sensitive. Even for varicella, nowadays we have PCR testing. So if there is an ultrasound finding, and the findings are like this, very typical, then we test directly on the fetus. Okay. When ultrasound findings are there and the fetus shows positive on PCR, then it is infective sequelae. You can be very sure. The sensitivity of PCR is quite high, in the order of 95 to 99%. Okay. When the mother comes, the situation is the mother has come because she is seropositive based on tests done for some other reason. Maybe primary screening, or sometimes obstetrician do for recurrent pregnancy loss. Then we hesitate to put the needle until ultrasound features are there. Okay. In one case, for example, in an actual case of maternal varicella. So varicella is very easy, it will be always symptomatic. So we said most of the ultrasound features, most of the infective features will be visible on ultrasound, but we need to give time. But if you want to be very sure, then you can go for amnio, we told. But amnio will not differentiate between infected and affected. That differentiation will come only by ultrasound. Okay. So there is a bit of catch in that advice also. What if it is just infected but never shows any sequelae? This can happen in varicella. So that couple then took long time, and by 24 weeks they came and said, no, we want. You said ultrasound cannot detect all manifestations, so we want to know. So now what to do? We were in a fix. So we were thinking that, okay, it should come negative. We put the needle, TORCH PCR came as positive. But the baby was clean. From head to foot, everything we said was clean. We did a thorough CNS examination. So it was very difficult to counsel. And then we consulted a ID specialist. And then we said, okay, take acyclovir for 2 weeks, and then we will see. So they took for 10 days acyclovir, and then they were happy to continue. Must have delivered it, find out what happened. Okay. Find out that.
Okay.
So the key point here is time your amniocentesis correctly. Okay.
So the prognosis depends on the timing of infection, the presence of fetal abnormalities, cranial and extracranial, and lab parameters. So always the maternal infection does not translate immediately to a fetal infection, and there could always be a lag period because the placenta, it acts as a reservoir as well as a barrier. And the fetal infection always need not manifest as an ultrasound abnormality. And the fetal cerebral abnormality or the cranial manifestations are the most important in prognosticating the outcome. So it can be an asymptomatic fetus, mild or moderately symptomatic, or severely symptomatic fetus. Asymptomatic when there are no manifestations at all. Mild or moderately symptomatic when there are really positive infection or an extracranial isolated manifestation. And severely symptomatic fetus with a full-blown manifestation. So we can, the viral load in the amniotic fluid will obviously be more for a symptomatic fetus than for an asymptomatic fetus. And recently, some fetal blood markers from the fetal cord sample has been tried, where we are looking for the platelet count because it causes some amount of thrombocytopenia, beta-2 microglobulin, and CMV IgM for the fetus. So these are also being used for prognosis. So when fetus is presenting with non-severe ultrasound features, the positive predictive value of an ultrasound alone in combination with an amniotic fluid viral load and other fetal blood parameters like platelet count, they have a positive predictive value of 60, 78, and 79%. So all ultrasound and the blood parameters put together has the high positive predictive value. The negative predictive value is ultrasound and viral load together 95%, and ultrasound and fetal blood parameters is almost like 100%.
Again, when we say positive predictive value, the background chance is very important. Okay. In a country where CMV is widespread, any CNS sign means they will first think of CMV. Okay. Whereas here we have been doing fetal jobs for so many years, hardly 1 or 2 has turned positive. Okay. Even though the traditional saying that in India we don't know the prevalence, we have been putting needle for more than 7 years now, directly testing for TORCH only. Anything we will do TORCH in the fluid also, anything in the CNS. So we haven't found much, 1 or 2 cases. How many did you?
One.
Yeah, there's one in Sonocare also. So this is all we found. So our background prevalence is very low. So any sign means it's not that. Understood? Background prevalence matters. In a country where tuberculosis is so prevalent, you take a chest X-ray, you see something in the upper lobe. Always our physicians will say, treat for tuberculosis first, then we will see. Same, you go to very high-profile countries, let's say Norway, cyclist. How will you have tuberculosis there? So there the thinking will be different, isn't it? So background prevalence matters when you speak about positive predictive values of different signs. Okay, tests perform as good as their background prevalence only.
So the management includes valacyclovir and some research is going on CME specific hyperimmune globulin. So this was one of the management guidelines which showed that in an asymptomatic fetus, we are going to just monitor with an ultrasound examination and a postnatal treatment. The valacyclovir is especially useful in fetuses with mild to moderately symptomatic fetuses, and it helps in attenuation or decreases the severity of the infection. In severely symptomatic fetuses, mostly we end up with termination because of the cranial manifestations or the cranial findings.
Hold on. With respect to CMV, one important thing that you should remember is the chance of sensory neural hearing loss in an apparently asymptomatic fetus. That means as a fetus, you could not find anything, nothing in the liver, nothing in the peritoneum, nothing in the brain, but the fluid showed positive. Okay, it's still 20%. Okay, it's still 20%. So remember that. How do we, this kind of patient we would never see, because we would never see means we would hardly see, because we are not going to test on a routine basis maternal serology and then do an amnio for the fetus. But these are data from countries where they do routine maternal serology as a part of national screening program and escalate those who had a seroconversion during pregnancy for an amniocentesis. You will still find sensory neural hearing loss. Okay, so CMV is a little bit bad. Other viruses, again, rubella is an exception. If you don't find it also, you will have defects. If you don't see anything on the ultrasound, you can still have defects. Okay, whereas varicella, you're okay. If you don't find it on the ultrasound, you're okay. Understood? Torch also, you're okay. If you don't find it on the ultrasound, the baby must be okay. Click.
So this was a study on the effectiveness and safety of prenatal treatment for congenital CMV infection. So it showed that there is decrease in the vertical transmission and decrease in the symptomatic congenital CMV infection. And it should be considered when the first trimester maternal infection is suspected on serology, and it's uncertain once the infection or the manifestations have been set in.
Okay, so predominantly in a universal screening setup, isn't it?
Yes.
Not how we do.
So once, even after confirmation in the antenatal period, we need to have a detailed postnatal evaluation of the baby, and we need to confirm it again on a urine sample or a saliva swab for CMV PCR after birth. And this is important to confirm that it's congenital rather than a postnatal acquisition. And prevention includes behavior modification and simple hygiene-based measures.
Go back. Yeah. So immediately the sample should be collected and they should demonstrate directly the virus. That is very important. Okay. It's very important from many different point of view, but also for medical legal. That's all. Huh?
It's the same.
Damage. Please unlock meeting. So next time I will we'll have to schedule it without waiting room. Okay, GP. Preeta, liver to be measured in coronal, and how about spleen? Yeah, liver is measured. You take a coronal view of the aorta and go slightly anterior. You should see the right dome of the liver bulging into the right dome of the diaphragm. From there to the lowest point along the right wall. Spleen, you take axial, oblique axial and measure the longest. It usually comes behind the stomach. Third ventricle cavum villi interposition. Okay. The third ventricle is wedged between the two thalami. So that's how you should see. CVI will be slightly posterior in location. IgM, IgG, positive 18 weeks with high avidity. High avidity, certainly, as I told, the risk of transplacental transmission is negligible. We can reassure. Seroconversion, what we have to look for IgG after. So seroconversion means a previously negative IgG becomes positive in the setting of a IgM positive. That is called seroconversion. Okay. In previously seronegative patients now detected with CMV specific IgG. What does it mean? Between that time and now, they have got an infection and they have developed immune status towards that. So the timeline will matter. Recently, a patient, 28 weeks, multiple CNS findings, hepatosplenomegaly. Maternal torch positive of IgG and IgM became indeterminate. IgG avidity is not done. How to interpret this? You should put a needle. That's all. There's no need to interpret. You are suspecting CMV. So it's better to put a needle and test the fetus amniotic fluid and go from there. If mother torch is negative for both IgM and G in ventriculomegaly, should you do torch PCR? No, if the lab is reliable, then you don't have to do. But in ventriculomegaly, anyway, you're going to put needle for genetic studies, isn't it? So since you have a very highly sensitive test, we can straight go for torch PCR. At least that is the argument that we have. So we don't go and test the mother. Usually fetus presents ultrasound features in late. I know what I'm telling is contradictory to the traditional opinion held. That is, first you have to get the maternal serology, then only you have to do the fetal. Okay. But over the years, what we have found is such things only. You'll be wasting time on maternal serology. When there is an indication in the ultrasound, test the fetus direct. Usually, where was I? Usually fetus presents. Ultrasound features in late trimester. If the infection is periconceptual, then serology shows it as old infection. Fetal features are due to infection. Okay, Shilpa, it's not the case. Can show in the mid trimester also. Can show in late second trimester, early third trimester. So anytime it can show, depending on the timing of the maternal infection. Okay. And generally, if ultrasound shows, the recurrent theme is this: if the ultrasound shows features, and features are not pathognomonic of any infection, we put the needle and test. Treatment regime of CME is if fetus affected at 22 weeks. So when you say affected, then the treatment is not really going to reverse, and generally it's a TOP situation. Early onset FGR, 22 weeks, structurally normal, placenta normal, low uteroplacental resistance, role of infection testing. I wouldn't do infection testing, Satya. Your experience on using valacyclovir, okay, the one or two cases we had, they had terminated. They didn't want to continue simply because we start from the fetus being affected on ultrasound. So that means it's a bad situation. Your treatment, your antiviral is not going to reverse anything. Okay. Head circumference is low, hoof centile, biometry appropriate. Do you need test for torch? No. Once again, if the head, it's a very good important question. Head circumference is low, you should call both parents and see how their head shape and size is. You should do an extensive intracranial anatomy, and you should schedule a follow-up visit with the counseling that, so for example, what she's telling is fifth centile or fourth centile at 22 weeks. What do? You have to schedule a follow-up visit at 4 weeks later, then 8 weeks later, and inform them that it is at the lower centiles. As of now, things look good. it can just maintain and go along because head shape varies widely, or there may be a late evolution of microcephaly. At present, the criteria do not fulfill microcephaly. So I wouldn't put a needle, but I would arrange all these follow-up. Can a CME fetus escape prenatal detection without? Yeah, possible. Yeah.
Hello.
And,
Hello.
uh,
Hello.
Can't hear. Hello, can't. Yeah, Dhaval, let's finish it. It's 9:10, I think.
Okay, so this one I want to know that suppose the fetus is infected by CMV, then what is the valacyclovir regime, sir? It's a continue from throughout the pregnancy, or it's just to 15 or 6 weeks therapy?
The throughout incidence. The throughout pregnancy.
I have
And
no idea.
postnatal
But
also baby has to be treated with
Because what the Dr. Professor Yale told in one of the conference, he told that throughout the pregnancy, but the dose is very the use of dose is very cautious, because the once we use 1 gram directly dose, it's a nephrotoxic. This is the drug also nephrotoxic for the fetus also. So it shut down the function of the fetus kidney, and it ultimately produces oligoamnios. So he told that just use 1 gram per day, but divide the dose.
as I told, 20% risk of. Okay, so maybe in a situation where the parents are very desperate to take the affected child, maybe, but I have no idea. Sorry.
Okay, sir. Thank you.
Thank you. Okay, guys, see you all on Monday. Okay, bye.